Hi, everyone. On behalf of the Citizen Science Foundation, I'm pleased to announce the Lean Mass Hyperresponder study is now underway. Certainly, a lot of you have been waiting for this, but some of you may not even know what a lean mass hyperresponder is or what this study is. And that's fine, because I'll actually be going through that through this presentation over a few minutes, and then I'll be getting on to an interview with Dr. Matt Budoff, who's our principal investigator for this study. So first things first, I think we need to kind of set the stage a little bit so that you understand why this is so significant. To do so, we need to go back about a half a century to the early 1970s with doctors Brown and Goldstein, where they were doing their seminal work and saw a pivotal patient that, in their words, actually determined the scientific course of the rest of our lives. And this patient was a little girl with homozygous familial hypercholesterolemia. It's a disease that results in very high levels of cholesterol in the blood, and the odds of getting this are about 1 in a million. And for those of you who are familiar with the symptoms, you'll recognize these are typical of somebody who has very advanced cardiovascular disease at a very young age. It's actually very heartbreaking. But in the words of Dr. Goldstein, this little girl had only an elevated LDL. She had no high blood pressure. She had no diabetes. She didn't smoke. She didn't have a type A personality. Her only risk factor for having a heart attack at age 6 was this high level of LDL. So it's one of the best examples of a disease where we really know the cause. The cause of the disease in this little girl is an increased level of her LDL. And bear in mind, while it is a 1 in a million that somebody gets homozygous FH, there are, of course, many other patients that they've seen since and that have been seen in other countries that have homozygous FH, for which there's this correlation that's frequently shown. In fact, you may have seen this study out of 2017. It's a consensus statement. In fact, it's right there in the title. Low density lipoproteins, LDL, cause atherosclerotic cardiovascular disease. And without breaking down all the metrics of this graph, I'll just point out that at the far end of each axis is LDLR for FH. In fact, the specific receptor mutation that Brown and Goldstein were looking at with this little girl. It's quite substantial in how much it can impact atherosclerotic risk. Or you may have seen this from 2018 from Snyderman, eradicating the burden of atherosclerotic cardiovascular disease by lowering ApoB lipoproteins. And over here, the most pronounced arrow, you can see the highest risk factor when looked at over age as the axes below is familial hypercholesterolemia, even without any corresponding risk factors. So without question, if high LDL as a result from FH is the primary driver of atherosclerosis in the absence of other risk factors, it provides compelling evidence for the lipid hypothesis. And that's where the low-carb diet comes in, particularly with data from recent years. Because of those going on a low-carb diet, there are some who will see a dramatic increase in their total and LDL cholesterol. For those of you who've been following me for a while, you know that this is my story. And we call these hyper-responders. But on top of that, some will see a specific pattern of high LDL cholesterol, high HDL cholesterol, and low triglycerides, which we like to call the low-carb lipid triad, a triad, these three together. And nowhere is this more pronounced than in this phenotype that I refer to as lean mass hyperresponders. And without getting into too much detail, I'll just say that this is a pattern that we've seen quite commonly, much more commonly than we would have thought within the low-carb community. And this is also what's common for lean mass hyperresponders. They have a lot of low cardiovascular risk factors, such as low insulin levels, low glucose area under the curve, low waist-to-hip ratio, low blood pressure, low HbA1c, low triglycerides, and of course high HDL, as I just mentioned. Yet, for high cardiovascular risk, they pretty much often just have one. The one thing we tend to associate, which is the high LDL cholesterol, high LDLP, high ApoB, pretty much all the same. And what it comes down to is this is a unique situation in that typically you have high LDL coupled with other cardiovascular risk factors that head in the other direction, such as those you see with, say, metabolic syndrome. Thus, we started the study. We crowdfunded it, and we just now launched it last week, which is why this is a bit exciting. So I'm going to go over the overview of it real quick. We're going to introduce you to the center running the study, the major eligibility criteria, how to join and what is involved, the crucial data we're collecting and why it matters, and an interview with Dr. Budoff. So let's start with an introduction to the center running the study. Well, you probably know those of us on the left, the Citizen Science Foundation. We're the team that's been funding and recruiting, getting the travel arrangement. The team we're working with is the prestigious Lundquist Institute. They're the ones who will actually be conducting the study directly. And this is led by, if you see the little picture down below, Dr. Matt Budoff. And Dr. Budoff actually has a fairly substantial resume. In fact, probably a lot of people would consider him the foremost expert in CT imaging, but at a minimum, many would say he's at least in the very top of the elite list for those people who have done so. He actually has over 1,200 papers to his name. It's quite astonishing. So now let's get to the major eligibility criteria for the study. And if you or somebody you know meets these major eligibility criteria, I would like to encourage you to check into contacting the Lundquist Institute if you are interested in volunteering. First and foremost, to be eligible for the study, participants must, 1, have been on their current diet for 2 years or longer. And given a lean mass hyperresponder status, this almost guarantees participants would be on what would be considered a ketogenic diet in practice, but we wanted to avoid using that specific term given it has many variations of meaning across social media. Bottom line is you just need to have been stably on roughly the same diet. 2, that there's been an LDL cholesterol of 160 milligrams per deciliter or below before adopting a low-carb diet. 3, having seen an increase of at least 50% or more in their LDL cholesterol to at least 190 or above since adopting a low-carb diet. Let me unpack that a little bit. So let's say that you had an LDL of 100 before starting the low-carb diet, and then it changed to 200 after. That would meet all 3 of these descriptions. You'd be below 160. You would have shifted to above 190, and that shift would have been about 100% increase, going from 100 to 200. But here's an example that wouldn't meet that. Let's say that you had an LDL of 150 that went to 200. Well, that would be below 160 starting out and then changing to above 190, but the increase would have been at 33%, which is lower than 50%. Again, Lundquist, when you contact them, can talk you through a lot of these in case any of this is confusing. Lastly, you need to complete the triad with an HDL cholesterol currently of 60 milligrams per deciliter or above, and triglycerides of at least 80 milligrams per deciliter or below. And if you meet all these major criteria I just described, I want you to join the LMHR study. If you're able to, you can visit citizensciencefoundation.org/study to learn more about this. That is our official link. Okay, how to join and what is involved? Well, I just told you. You can contact the Lundquist Institute to confirm eligibility through our official link. They'll take you through an interview process, and from there, if you qualify, you schedule an appointment with Lundquist. And at that point, Lundquist alerts us, the Citizen Science Foundation, to schedule your travel. And everything I'm about to talk to you about with regard to the travel is something that we pay for through the study. So, what is that exactly? Well, here's the overview. You'll fly to LA for the afternoon or evening before your appointment, check into our official hotel, get plenty of rest. You may enjoy dinner on us if it's not too late in the evening. But we want you to plan to be 12 to 16 hours water-only fasted for the morning appointment at Lundquist, where you'll get your CT scan, blood work, and so forth. Then finally you fly back home. On the year in between, you'll be testing your blood every morning with a Keto Mojo device to confirm the beta-hydroxybutyrate is generally at 3 millimoles or higher, just to confirm your remaining low carb. And at the midpoint during the year, Lundquist will check in on you with some additional questions. Lastly, you'll have a second appointment roughly about a year later, where you'll repeat everything you did in the first visit, flying there, checking into the hotel, being fasted for the morning appointment, getting another CT scan, and then flying back home. So the crucial data we're collecting and why it matters so much. We're tracking plaque progression. It's assumed the vast majority of people have some degree of overall plaque progression, known as atherosclerosis, over time. Capturing plaques by CT angiograms at one point in time, and again at a later point in time, known as longitudinal data, gives us enormous insight into the overall progression level of atherosclerosis, particularly at a population level. To be sure, high-resolution CTA longitudinal data has mainly been collected on high-risk populations, not on low-risk populations, but that actually gives us plenty to work with. We'll have powerful data when combined with single-scan studies of both high and low-risk populations for comparison. Again, remember the example of familial hypercholesterolemia, FH, and how rapidly we see increased plaque levels for that context. If you're looking at LDL cholesterol in the general population, note that less than 3% of the US population has an LDL cholesterol of 190 milligrams per deciliter or higher. So I'm showing you 100 different figures. That's three out of 100. And technically even then a little bit less than that. So given lean mass hyperresponders have an LDL cholesterol in the top 3% of the US population, it would commonly be expected that they would likewise have a high progression of atherosclerosis, such as in the highest third for the general population. In other words, you could try to mitigate these factors in many other different ways, but at a minimum, you would likely be in the top third, given what we would already expect. Conversely, where lean mass hyperresponders have an LDL cholesterol in the top 3%, it would run counter to conventional expectations to observe a low progression of atherosclerosis, such as in the lowest third of the population. This is why I like to talk about this as a big versus small magnitude of plaque progression. Plainly stated, a high magnitude of plaque progression is easy to detect with CT image comparison in a very short span of time. Many existing studies have already demonstrated this. And while we will certainly be looking at many more aspects of these plaques, their morphology and so forth, their overall progression at a population level will help provide powerful evidence regarding magnitude of expected risk. And interestingly, as we get closer to the study, there have been many, both pro and skeptic, I guess you could say, the Lipid Hypothesis, who predict lean mass hyperresponders will demonstrate a low progression of atherosclerosis, but speculate their progression would be even lower were every risk factor the same, save a low LDL cholesterol rather than a high. In other words, lean mass hyperresponders would be, in their words, low risk, but suboptimal when compared to the lowest possible risk. Given our study doesn't have a control, it is unlikely to provide much in the way of answering this speculation if the plaque progression were low enough to suggest this. Regardless, low progression of plaque for lean mass hyperresponders at a population level would be a substantial finding if that's what we see in the outcome. Again, no one knows what these data will show until the study is complete. What's neat is beyond CTA, there's a unique opportunity to advance science through wide spectrum genetic and blood testing. And I'm very happy for these partners, GB Insight, Nightingale, LabCorp. They're all going to be providing a lot more data above and beyond just what we're getting with CT angiography. And now I'd like to introduce you to Dr. Budoff and this discussion that I had with him regarding the study, CTA, and its implications. It's worth every second of your time, no question. Dr. Budoff, thanks for joining me.
Oh, my pleasure.
Heart disease is the number one killer in the world for almost a century now. The number one target for prevention and treatment is LDL cholesterol. Now I looked, and it appears it's been almost about 50 years since doctors Brown and Goldstein merged their laboratories to start the seminal work that would eventually earn them the Nobel Prize in finding that high LDL, particularly in those who have familial hypercholesterolemia, demonstrated a high rate of atherosclerosis, particularly in those who otherwise didn't seem to have any other cardiovascular risk disease factors. Would it be fair to say that we know of no population for which high LDL doesn't have a likewise association with high risk of heart disease?
That's, to my knowledge, that's correct.
So we're now embarking on something truly new, very different, because up until this point in time, there hasn't actually been such a thing as diet-induced hypercholesterolemia that you're aware of, right?
Yeah, not to the degree that we see with these specific diets. Obviously, people can eat poorly and their LDL can go up a little bit, but not to the degree that we see with these type of diets.
Have you yourself, before even we started chatting, do you have patients under your care who exhibit these same profiles that we're going to be looking into for the study we're about to do?
Yes, I have a few patients who've, through relatively aggressive diets, have raised their LDLs considerably.
And granted, any amount of data that you've gotten up until this point is very limited necessarily, because this is just a handful of people.
Yeah, it's a handful of people, and they weren't followed prospectively and looked at in any systematic way. So really, the only way to assess this is to really do a systematic study.
Right. Now, to be fair, some people are going to raise concerns. They're going to say, look, at the end of the day, we have more than enough data that high LDL will result in a high progression of atherosclerosis. So we really shouldn't even bother doing a study. We should make sure that everybody who does have high LDL take on treatment to lower it. Do you feel that that should preclude us doing a study on this?
No, I think there's definitely equipoise here. We have evidence that these patients in general, despite their high LDLs, do well over time. So there's anecdotal evidence or non-randomized evidence that they do well on these type of diets despite the high LDL. And then obviously we have this LDL hypothesis that would argue that these high LDLs are bad under any circumstance. But I think there's enough equipoise that we should do a clinical trial to kind of establish the right answer.
Do you think there's anything of special interest with there being also a high HDL cholesterol in combination with low triglycerides when combined with a high LDL cholesterol?
Yeah, I think that HDL, while it's been somewhat maligned over the past few years, is still a very good predictor of future cardiovascular disease. And we use ratios, total cholesterol to HDL or triglycerides to HDL, to try to establish how atherogenic or how dangerous a condition may be. High HDL is very well established that it's protective for cardiovascular disease. So a high cholesterol, total cholesterol, or LDL, and a high HDL may actually balance in many cases. And there's a lot of good examples of that as well. So a lot of this potential harm of high LDL may be offset by a potential benefit of high HDL.
It's interesting because I find, even though I proactively emphasize, me personally, that I'm quote unquote cautiously optimistic with this context, with high LDL and the context of it being from metabolic fat adaptation, that even that position by itself is considered very controversial. And I'm sometimes described as a controversial figure. That position alone is problematic in trying to move this science forward. Would you agree?
Yeah, I think whenever you have a majority of people who feel that one answer is much more likely correct than another, then there raises questions about whether you should allow people to continue to be exposed to this. But again, I think that there's, especially with high HDL and low triglycerides, we know that that's a cardioprotective state. And now we have some evidence that, we have to see how the two balance out.
Right. We certainly agree that while a lot of this anecdotal evidence may look good, there's still lots of problems. There could be selection bias. There could be a number of people that we don't know about for which survival bias may play a part. Therefore, we need a prospective clinical trial, right?
Absolutely. And I think anybody who argues that we don't need a prospective clinical trial is probably coming from a pretty extreme personal viewpoint, because we've been surprised before. Things that we thought were obvious hormone replacement therapy in women. It was obvious from the observational data that they would benefit from that. And some people said we don't need to do a clinical trial. Why put them on placebo and risk? And then we found out that the estrogen replacement had no benefit for these women, and that we were exposing millions of women to something that might actually be having some side effects and not affording them the benefit that we thought it was. So randomized trials proved that some of our observations are incorrect.
So our central test for this trial is going to be a CT angiogram. Can you explain why this is a superior test for us to be tracking the progression of atherosclerosis?
Yeah, I mean, really, it's the only test that affords us the ability of looking at plaque in the coronaries over time in an asymptomatic or less symptomatic population. The only alternative is intravascular ultrasound, or what we call IVUS. But that's really unethical to take a relatively healthy or person who feels well and subject them to a very invasive test that has a risk of causing very serious complications, including death, as an adverse event. So I think using a less invasive tool that gives us really good definitions of plaque and plaque quantity, and then assessing them again with that same non-invasive tool, is going to be the only really option that we have to really answer this question.
Now, it's going to be difficult for us to compare this to a truly healthy population because, as I understand it, we don't actually have a lot of longitudinal CTA data on healthy populations with low progression of atherosclerotic plaque. Would that be correct?
That's correct. We have some new evolving data sets of population-based assessments of CT angiography. There's a study we're working on called Miami Heart, which took healthy people and got CT angiography. That's only one point in time, so we don't have the progression rate in that population, but at least we can look at prevalence of plaque and compare it to that healthy asymptomatic population as one point of reference. But yes, this is fairly unique, and that's usually why we have placebo groups or some control group to make sure that the rates of progression that we're assessing in the active group is different or is similar to a controlled population.
This actually is a good thing to bring up because we are likely going to need to address this. A lot of people would understandably say, hey, why not go ahead and also have a control group? But as I like to try to explain, we have a bit of a problem. It's actually so ubiquitous that people who are very lean, athletic, and very low carb actually exhibit this particular lipid profile that it's actually harder to find people that exhibit all those three and don't get the lipid profile. But on top of that, it's actually hard to get a lot of those who were already non-adherent to treatment options to now go on, say, medical therapy, such as going on a statin or something like that to lower their LDL to then become a control group. So a lot of us on our team, we acknowledge that this is a pilot study. You know, it's the beginning of a chapter, not necessarily the end of one. Would that be a fair statement?
No, absolutely. And we have many other cohorts to look at rates of progression to at least have some basis of comparison in the absence even of a control group to be able to assess, you know, where this group lies in the spectrum and the rates of progression and what we've seen under the influence of different therapies.
The way that we've set this study up, even though myself, Doctors Spencer Nadolsky and Tommy Wood are the originating team that have come to you and Lundquist to get this study done, at no point in time will my team actually have access to the identified data. Is that correct?
That's correct. By definition, we have to be protective of all patients' privacy. These HIPAA laws, health protection laws, and make sure that the privacies of all of the participants are maintained, and also the integrity of the study is maintained. So it'll just be my investigative team that'll have access. And even when I read the studies, I'm blinded. I don't know what patients are on, what therapies, or what their LDLs are, or what they are done. And when we read the follow-up studies, we anonymize the time. So we don't even know which study came first. So we'll look at two studies side by side, but first study, second study will be unknown. So if we see progression or regression, we won't know which one it is until the readers are unblinded. So we take all of this blinding very seriously, and certainly your team won't have access to any of the data until we've finalized our analyses.
Well, and that's also important because there may be some who raise concerns that our team could have access to it, could change things, could manipulate things. That's all not even possible.
That would never be possible. Our statistician is really the only person who would have the key to unblind any of these studies. So everything else will be anonymized by my research team, by myself, and then ultimately any data that we share with you would still be bundled and anonymized. You would see Group A or Group B, or you might see a spectrum of patients, but you won't know who they are. They would just be patients 1 through 26 or 1 through 42 or whatever we have at the time when we're doing our initial analyses.
Likewise, there's going to be some on the skeptic side of the fence who will possibly think that maybe calibrations or software might change from the first set of scans to the second that might make it look as though there was more plaque that developed in the second set of scans. All of that's not really possible, right?
Yeah, that would be impossible, because when we read the studies for plaque quantity, our final endpoint, together with both scans paired. So whatever software we're using at that time, it's going to be the same for scan 1 and scan 2. And again, because we anonymize the date, we don't even know which one is really scan 1 or scan 2. So it'll just be read. So, even if somebody thought, oh, the reader may have a bias that people with high LDL should progress, they won't know which scan is the first one taken and which is the second one taken. So they won't even even that potential bias is impossible to interfere in our interpretations. And it's all automated software anyway, so it really is not that user dependent. So it's really very trivial opportunities to bias the work in any way.
So at the most basic level, we can effectively just compare total plaque volume versus total plaque volume. Would that be correct?
Yes, I mean, I think there's different endpoints that we're going to decide in advance, so that it's all predetermined. So we don't look at the final data and then say, oh, that's interesting, let's make that our primary endpoint. But it'll all be predetermined. We usually use non-calcified plaque as our total non-calcified plaque as our primary endpoint, just because calcified plaque doesn't change at the same rates as the other plaques do and might be influenced by other factors. But that's predetermined, and that's going to be standardized to all of our other studies that we've done. And we've done a lot of these CT angiographic studies. This will be probably our 14th or 15th randomized trial looking at different effects. We've done things with garlic therapies, we've done things with fish oil therapies, and we've done a number of traditional medications, prescription medications with randomized trials looking at the effects of plaque over time. So again, we'll have a lot of comparator cohorts to look at, as well as looking at this cohort as a standalone.
Well, thank you so much for your time, Dr. Budoff.
It's a pleasure. Thank you for having me.
I'd like to now finish with a special thanks. I have so many to thank, but there are a few that require special distinction. The first, everyone past and present and future who have reached into their pockets and contributed to the citizensciencefoundation.org to show their support for this study. This historic endeavor simply wouldn't be possible without your help. Thank you deeply. Also, second, the staggering generosity of Keto Mojo and GB Health Watch. Both of these incredible companies have contributed 100% of their product and services to this study. Lastly, a very big thanks in advance to the amazing participants who will be joining this study. While I certainly admit my bias before saying this, I truly believe this research will provide us a wealth of data unlike any other. So, thanks for watching, and if you or anyone you know might be eligible for the study, please visit citizensciencefoundation.org/study, and for social media, please use the hashtag LMHR study. Thank you.